Okay. Well, this topic is really important, not just to us, but to everyone, particularly in recent years, as there's been just a really rapid growth of clinical knowledge, and there are a lot more research publications, clinical research publications, a lot of information out there. And what that means for us is it can be overwhelming at times to know even where to begin to try to get sort of a handle on what's going on and what are the best practices. It can leave you feeling sort of a little overwhelmed. And what we'll talk about tonight are a few things. First, how much of this knowledge is going to be useful to you? How can we decide that? How can you evaluate the quality and the relevance of the research, all the research that's out there? And then to try to develop some tools so that you can not only appreciate what this is, but to participate yourselves in this endeavor of clinical research, which is really a lot of fun. And I think that that anyone who loves to do anesthesia and is interested in the growth of the specialty, and it will be very should be very excited about the possibility of contributing to the specialty in this way. So the goals of the talks are going to be really to review the fundamental components of clinical research design. That's tonight. And these concepts will help you to do several things. One is to decide the clinical relevance of a study and its findings, anything that you read. To identify some common sort of limitations of study conclusions. Identify findings that are likely to be of value to you and to your ability to take care of patients. To understand the presence of what seem to be conflicting findings, that is, conflicting within one paper or between different by different people, is very confusing and disheartening. And what we'll talk about tonight are some ways to kind of make sense of this. And then to identify what a valuable research question might be, and then to start there and look at appropriate study methodology so that you can go about obtaining the answers that you want. Before we go further, I wanted to just give you a sort of overview of the outline of a study protocol. Now, this looks very specific, and you read a research paper in a journal, you don't see things written out this way. However, this is the blueprint that you go by when you're going to do any clinical research, and I would say that before you even get started, you want to have all of this sort of decided in advance. The first thing, obviously, and most importantly, is your research question. That is, what question or questions do you want this study to answer? Now, how do you decide if a research question is a good one? And there are a lot of different ways that people have described this, but I like the acronym called FINER, and it's called the FINER criteria. And these are supposed to be 5 elements that are all very important to evaluating the merit of a clinical research question. First, is doing the study is it feasible to answer the research question by the study that you intend to do? Some studies are very easy, relatively easy to answer, while others would be far too ambitious. So the first criteria will be, is this a feasible study? Secondly, is the topic interesting? Would the answer to the research question provide novel or new information? Is the study ethical? That is it fair to the participants? And does it hope to increase ethical aspects of medical care going forward? Is that part of its purpose? And I think the last would be, would answering the research question provide clinically relevant information? So if you can say yes to all 5 of those criteria, I think that one would say that your research question is very good. The background and significance really talk about why the question is important. And that can be a very lengthy section of your protocol and is something that really is worth doing a lot of research on in advance, a lot of reading. And you want to decide first what is already known about the topic. So you want to start there. You don't want to study what's already known, but you want to start with what is known and then decide what the next logical step would be. You need to address why your research question is important. Does it address an important clinical problem that's not been met, where the solutions have not been met to date? Or does it address certain uncertainties in our current knowledge? Could the findings from the study actually change clinical practice or health policy for you and your institution or for others in other areas? And might these changes in practice be beneficial to patients, to other doctors, or to society at large? All of those issues are things you want to talk about in the background and significance section. The next issue is going to be the design of the study. How is the study really going to be structured? And we talk about the epidemiologic approach and then the time frame over which the study is going to be carried out. So with the epidemiologic approach, what we have to ask is what is the most appropriate, efficient way to answer the study question. Ask yourself what your resources are, how much time you have, how much money you have to spend, and how many subjects you think you can be able to recruit, or if you can recruit subjects at all. What kind of measurements will you need to be making? And the basic decisions kind of break down into this. The diagram sort of describes how these decisions break down. If you, on the left here, if you're going to actually perform some kind of an intervention, that is, you're going to do something to give say a medication to a patient or manage them in a specific way that's experimental. This is considered an experimental design. And if you are, so if you intervene in some way, we would call this an experimental study. If patients are assigned at random, this is random allocation, meaning you get drug A or drug B, you get drug A or procedure X.
Hold on. Yeah. Please turn off.
That is a randomized control.
Please turn off your microphones. Thank you. Okay.
That would be a randomized controlled trial, where if that's not the case, you may still do an experiment, but it may the interventions would not be assigned in a random manner. If, on the other hand, you are not going to perform an intervention, that is, you're going to just look at what's going on, you're going to examine data. This is an observational study. If you're going to compare different groups, say groups getting one drug versus another or one intervention versus another, that's an analytic study. If what you're doing instead is trying to describe, say, causes of death or incidence of disease, and you're not comparing anything, that's called a descriptive study. But if you do plan to compare groups, this is analytical, and then you can subcategorize the analytical studies as follows. You can certainly look at a cohort of subjects over time. You can look at patients who have an outcome that you're interested in and compare them to patients who don't have an outcome. That's called a case control study, or a cross-sectional study where you're looking at both the exposure and the outcome at the same time. We'll go a little bit more in depth into what all this really means. So descriptive studies, as we said, are where we are only studying one group of patients and describing an incidence of a problem or trying to raise awareness of a problem. These are very useful in sort of getting an idea of the totality of a problem, the denominator of a problem. Say, examples might be leading causes of mortality after surgery in the United States, the prevalence of childhood diabetes.
Rochelle, can you repeat the slide before this again, please?
Yes. Did you want to see this slide again?
Put all the slide.
Yeah, this is the
I'm
slide.
sorry?
Yes. Can you repeat what you said about it? Can you say again what?
You want me I can start, yeah, start at the beginning?
Summarize it, yeah.
Yes. So we essentially are looking at two different basic designs. One is going to be one where you have an assigned intervention. So you're intervening in some way with a patient. Say you're doing something to the patient, giving something new to a patient, whether it's a new kind of a drug or an intervention, a treatment, a certain kind of surgery. These are all interventional studies. And we would consider those an experiment. And whether the patients are getting the intervention or standard care by random allocation or random assignment is going to determine whether it's a randomized trial or a non-randomized trial. A randomized trial would be where the investigators were blinded to the randomization. You may have an assignment in a sealed envelope, for example. Although it's electronic now, the concept is that the assignment of the intervention is going to be completely by chance. It's going to be, in other words, you don't get get drug A or B depending on any characteristic other than just what number in line you were in the study. So the idea is the assignment of the intervention should be done to patients regardless of any baseline characteristics they may have. On the other side, we have observational studies, and I would tell you that the majority of studies you read in the journals these days are observational. They're not interventional. You're going to have two basic types of observational studies, one being descriptive, where no comparisons are made. You're simply making a statement about the incidence of a problem, versus where you are comparing people with an outcome, saying and trying to figure out why people died or why people had heart attacks or strokes or stayed in the hospital, and those are analytic studies. And then we'll talk a little bit more about this direction of exposure, but basically three main categories of these analytic studies are going to be cohorts. So an example would be studying an entire population of a city and studying them over years and years and looking at all the people who, for example, smoke or who drink a certain kind of water or who have high blood pressure, and looking at what happens to them over 10, 20, 30 years as a result of having these different risk factors. That's a cohort. That's like studying the cohort. A case control study is a study, and I'll go over some examples in a minute so we don't have to remember all this. A case control looks at people with a certain outcome and then tries to compare them to other people who don't have that same outcome. And then cross-sectional studies are studying things that sort of at the moment, studying people who have different risk factors and trying to determine the impact of those risk factors on an outcome. So the descriptive study, again, is useful to try to raise awareness of the prevalence of disease in a population, or the sort of the impact of various problems in a group of patients. Examples being, what are the leading causes of mortality after surgery in the United States? Within a week. That's actually not a trivial question to answer, and that's something that we've tried to make sense of for years. The prevalence of childhood diabetes in a particular community. What's the prevalence, say, in Palestine? What's the prevalence in California? So trying to get an idea of how common a problem is. Boundaries to access to specialist care. Do people in a certain community have difficulty going, for example, to see a cardiologist? These descriptive studies tend to generate information and ideas then for further analytical studies or even interventional studies. Mm-hmm. And these are studies where no particular statement of hypothesis is needed.
Rachel, can I add something? one of our very beloved daughters, Hadil Ghaith from Maqasid Hospital in Jerusalem. In 2011, for example, presented a purely descriptive study of the modalities of anesthesia for cesarean sections at Maqasid Hospital, and it turned out that from her review of a lot of records, that 80 or 90%, something like that, was done under general anesthesia. That's all she did. That purely دراسة وصفية بتصف أسلوب التخدير في القيصرية. And yet it caused quite a stir in Buenos Aires. Magdi El-Baradei was with her, and people are very surprised. So to raise awareness, as it says on the first line of your slide, that is the main purpose of a descriptive study. Today, this number is a lot lower than 80%. I don't know what it is. We haven't studied it, but it's a lot lower than 80%. So yes, descriptive studies have that role. Thank you.
Yeah. Okay. So in an analytic study, we'll talk more specifically about the three basic types of analytic studies. But to look at these designs in further detail, if we talked about various observational studies here at the top, and one is the cohort study, and this is going to be the key feature here is that there's a group of patients that are followed over time. And examples of research questions asked during cohort studies would be the risk of cigarette smoking, it would be cigarette smoking and the risk of developing coronary artery disease. Other examples would be the Framingham cohort, which looked at people with various levels of hypertension on development of heart disease over years. A cross-sectional study is, in terms of its time feature, it's a group examined at one point in time, and they can be examined either prospectively, meaning you'll follow these subjects into the future, or retrospectively, where you look at a group and you look back at events that have taken place in the past. One prospective study that made quite a bit of impact a couple of years back was whether the use of a paravertebral block for breast cancer surgery had impact on the risk of the patient developing metastatic disease over time. Now, these patients did not get randomized to get paravertebral anesthesia or general anesthesia, but what they did look at is over time in future whether these patients developed breast cancer that was metastatic and widespread, I think 18 months or so after the surgery took place. Retrospective studies look at events that happened in the past, and one that actually created quite a stir about a year ago was one in which a large number of patients were evaluated who had, and some of whom had received etomidate at some point during their hospitalization. And the findings suggested that the use of etomidate in patients was associated with a greater risk of death during the hospitalization. Another main study design here is a case control study. Two groups are compared. One would be patients who have a certain outcome. Usually it's an adverse outcome. And when you take those patients with the adverse outcome and you find matched patients who you call controls, that is those who went through the same surgery, let's suppose, or is the same age, but didn't have that same outcome. And then the research question asks what factors were associated with the outcome. And an example of a large case control study would be one in which factors associated with death within 24 hours of surgery were evaluated. And we can talk more about that either tomorrow night or later on in the weekend. Now, if you're going to do an interventional study, these are clinical trials, And the most common and the most useful of those designs is the randomized controlled trial. Typically, the investigator is, as I said, unaware of the assignment to intervention or control of the patient. And these are typically things like impact of a drug versus a placebo on outcome, or impact of drug A versus drug B on an outcome, or a new intervention versus standard care and its impact on outcome. And I'm going to let Dr. Hafez read this, but this is in Arabic, trying to give a little bit better description of what these studies are.
هي بس ترجمة للمصطلحات يا شباب. يعني cohort يعني cohorts أترابك. يعني أترابك يعني تعرفوا أترابك. واحد ممكن مقارنته بيك في كل شيء، في السن وفي الحالة الاجتماعية وفي الحالة المادية وفي الحالة الصحية والعادات، القهوة، السجاير، الأرجيلة، مش عارف ايش، بتاخد أدوية ما بتاخدش أدوية. فالكوهورت كوهورت في الحقيقة هي مصطلح إحصائي من الكتب العربية في الإحصاء. مجموعة من المرضى ذوي مشكلة ضد مجموعة من المرضى من أترابهم صحة وسنا إلى آخره بدون المشكلة تحت الدرس. هي ليست جاية يا حمام، الكوهورت ستادي عادة ما بتكون دراسة بتنظر إلى الوراء، بتنظر إلى ما حدث في السابق. فبتاخد مثلا قررت انك انت دراستك عشان تتقصى الحقائق محتاج 1000 مريض، 500 مريض عندهم سكري و500 مريض ما عندهمش سكري. طبعا مش معقول هتاخد ال 500 مريض اللي ما عندهمش سكري شباب رياضيين هيك، والشباب والمرضى اللي عندهم سكري اللي هتقارنهم بيهم عندهم ختياره وكبار وعندهم ضغط وعندهم هيك. فلازم تاخد مجموعه من الاطراب، مجموعتين من الاطراب، 500 عندهم سكري، 500 ما عندهمش مثلا. ولكن ال 500 اللي ما عندهمش سكري يقارنوا اطراب ال 500 اللي عندهم سكري، والفرق الوحيد ان ما عندهمش سكري. اوكي. كروس سكشنال ستادي يعني دراسة مقطعية، يعني بتاخد مقطع في جميع مجموعات المرضى، اوكي، الأعمار وهيك. كيس كنترول ستادي، كيس وكنترول. الكيس مجموعتان متشابهتان في كل شيء، لكن مجموعة لها المشكلة المطلوب دراستها. ايه الفرق بين الكوهورت ستادي والكيس كنترول ستادي؟ ان الكيس كنترول ستادي عادة بتكون مستقبلية زي ما بيقول الدكتور مصطفى خريشي، يعني بتنظر إلى الأمام. يعني أنت بتنظر إلى الأمام، بتحاول تعمل تدخل ما، مثلا بتعطيهم أسبرين، مثلا بتعطيهم الدواء الفلاني ألف ب أو ج، أوكي، وبتقارن مجموعتين، مجموعة من المرضى اللي هم الكيس اللي أخدوا التدخل الدواء مثلا، وكنترول اللي خدوا اقراص تباشير. اوكي، اقراص الطباشير طبعا ما لا قيمه لها، بلاسيبو مثلا. فممكن تقول كيس كنترول بلاسيبو ستادي، او كيس كنترول دواء قديم ضد دواء جديد مثلا. افرض في دواء جديد للسكري وبتقارنوا الكيس، يبقى مجموعه المرضى اللي خدوا الدواء الجديد، الكنترول المرضى اللي خدوا الدواء القديم. الراندومايزيشن يعني عشوائيه، وترجمناها قبل كده. والعشوائيه مش سهله بالمناسبه يا شباب، حتى لو خدت كورس. اوكي جود، ثانك يو. سوري.
Okay. No. Thank you. That's good. I'm glad that make sure that it's clear that it's not too jargony. So the cohort study design, again, just to reiterate, it's a group followed over time, and you follow these people who all of whom, some do and some don't, have a particular risk factor. You follow them over time, and you see who does or doesn't get a disease or an outcome that you're interested in. So examples would be, there's a lot of concern about infants and toddlers getting anesthesia at that early stage of life and its impact on their future intelligence and ability to learn and behavioral issues. So a cohort is, there are cohorts of young, very young kids that they're studying now, and they're trying to look at those who do and don't have anesthesia and look at their, over time, their performance in school and their development of any behavioral problems. That's an example of a cohort. Another would be looking at a large group of women and looking at whether their exercise and dietary habits will impact the risk of developing diabetes or chronic pain in the future. That's another cohort, a cohort of like individuals. Or how does the increased blood pressure affect the risk of developing subsequent heart failure, stroke, or kidney failure? And that was really looked at in this cohort from Framingham, Massachusetts. It's very well known, and they looked at people both with and without hypertension and looked at how that impacted their future health. So the cross-sectional studies can be, as we said, prospective or retrospective. And Hafez, if you want to talk a little bit about those two terms.
I hope it's self-explanatory. No, I hope it's self-explanatory. فاهمين الموضوع الفرق بين prospective مستقبلي و retrospective. I don't know how to translate retrospective model. Anyway, okay.
I have a question. If we do prospective study or retrospective study, do we need to have a consent form from the patients?
Great question. The answer is it depends. Some retrospective studies that are in where you have are looking at large databases of information. You don't have to have a consent form from a study, but what you do need to get is institutional review board permission to look at the database. So the idea would be that if looking at the data would impose minimum risk to the subjects at this point in time, then you can get permission from an institutional review board. If you are looking at certain things retrospectively, it's pretty hard to go back and get consent from patients, but I think it depends on what you're going to look at. If you're going to go back and ask people questions about, about their health, then you would have to get a consent form. If you're going to look at administrative data or data that's available, say, electronically or in the chart, and your institutional review board determines that this is of minimum risk to the patient, then sometimes waivers are granted for that. But it's kind of depend on what you're looking at. Definitely looking prospectively, you will need to get consent for most patients for most things. So the timing again of cross-sectional studies, prospective studies can be, if it's just a cross-sectional study that's not a randomized trial, then by definition the intervention was not assigned at random. And these studies are often done when one might consider one kind of care compared to the other to be less effective or less beneficial or possibly less safe. It's very difficult sometimes to ethically assign somebody at random to getting one kind of care or another. So so many times we study these things in going forward, but we look at which patients get what and these things. And a perfect example would be the impact of getting general anesthesia or spinal anesthesia with a C-section and the impact on the baby's health, let's say, or the mom's health. And that it would be very difficult, I think, to convince an institutional review board that it's ethical to offer to assign a patient at random to getting a general anesthetic for a C-section, because I think we know enough to know that general anesthesia has quite a few disadvantages for the patient and for the baby. But if you looked at things where things may reflect a patient's preference or sort of regional practice patterns, then it's quite different. So one perfect example there would be patients getting regional or general anesthesia. It's difficult to assign people to that because patients usually have a preference, but you can still try to take a look and look forward and see, you know, what impact that that kind of anesthesia would have on the patient's outcome in some way. These can also, prospective cross-sectional studies can even include small sort of experiments that may be, you know, physiologic in nature. Retrospective cross-sectional studies, often large numbers, many tens of thousands, hundreds of thousands of patients can be examined. And this is more and more common now because we have a lot more data available to us. So the advantages are that it's not as expensive, because it's very expensive to study patients individually, to get consent and to follow them and collect individual data. It's also a lot less time consuming, but we'll talk about there are numerous disadvantages there too. Examples of some cross-sectional studies, one which we mentioned already, and that is, does use of paravertebral anesthesia compared to general anesthesia for mastectomy surgery influence the risk of developing metastatic disease? A small study that was done that I think we presented a couple of weeks ago was, does advanced age impact the hyperventilation response to hypoxemia? Or do low intraoperative BIS scores, being a process signal EEG, which is essentially giving the indication of hypnosis while a patient's getting surgery, and do very, very low BIS scores have impact on postoperative cognition or morbidity and mortality? Those were all sort of studies that were done prospectively. Retrospective cross-sectional studies examples might include, did the patients who received etomidate have increased rates of postoperative morbidity and mortality? Did the use of nitrous oxide versus oxygen and air influence risk of 30-day mortality and non-fatal MI? Or did mild intraoperative hypothermia influence the risk of blood loss and wound infection? All of those questions were asked retrospectively. Case control studies, again, two groups compared, one with an outcome of interest and a similar group without that bad outcome, are used as a comparison in order to try to determine what factors were associated with that outcome. So essentially, again, comparing people with or without a disease, you'd find an outcome of interest, examine factors that have an association with the outcome. So examples would include anesthetic-related cardiac death or arrest, cardiac arrest or death, neurologic injury, development of chronic pain after surgery, critical events that occur during recovery, or explicit recall of events in the operating room during general anesthesia. Now, one thing you notice about these things is that they can be very rare. Examples can include comparison of patients with who have had critical respiratory events in the recovery room of a large teaching hospital over a one-year period, or characteristics of patients who died within 24 hours of surgery among over 860,000 consecutive cases in several large hospitals in the Netherlands. So trying to get a very big denominator. So if you're planning this experiment and you're going to do, you're able to obtain consent and assign patients at random to one of two interventions, you're doing a randomized trial. And this has got to be, assignment has got to be at random. So that's one very important feature of these studies. And this is a definition of randomized controlled trial in Arabic. And this is going to be impact of a drug or versus placebo, or impact of standard care versus a new intervention on an outcome of interest. So these are really the gold standards in studies. Patients assigned at random to one intervention. The investigator who judges the outcome must be blinded to the randomization. of all of these patients. These are the most time-consuming and expensive studies, but there are numerous advantages which we will discuss to doing them. The principal advantage is this is really the only study design that has the ability to prove cause and effect, not merely just pointing to associations of variables together. They have the carry with them the highest level of evidence, and randomized controlled trials are required by regulators, including our Food and Drug Administration in the U.S. and many other national similar regulatory agencies for approval of new drugs and for, in many cases, approval of new devices. So that can mean implanted devices such as intrathecal pumps and pacemakers and defibrillators, etc. So examples of randomized controlled trials that one which we talked about in the preoperative evaluation lecture was the question of the impact of long-acting beta blockers on mortality and non-fatal MI within 30 days of surgery. The POISE trial looked at beta blocker versus placebo. POISE 2 trial looked at aspirin versus placebo and clonidine versus placebo. One trial that actually changed a lot of practice was the so-called CAST trial, which was cardiac arrhythmia suppression trials that were done in the 1980s. And those were trials in which patients who had suffered MIs and had arrhythmias were given antiarrhythmic drugs to suppress the arrhythmias, suppress PVCs and so on. And it was actually found that the use of these antiarrhythmic drugs was associated with greater mortality after heart attack. Nobody really expected to find that. I think a lot of times when we worry that the things we do in practice that would seem to be good for patients, if we don't study them, we may actually be doing the opposite. We may be doing nothing or doing more harm than good. So that was an example of a randomized controlled trial that actually changed practice considerably. Another is the ARDSNet study looking at low tidal volume ventilation in patients with ARDS and the risk of mortality and the impact on so-called ventilator-free days. And that's a study which was actually stopped. The findings that this low tidal volume ventilation with higher PEEP was so protective that they couldn't continue ethically to randomize patients to the other intervention. So another example of going backwards
Rachel,
looking at observational studies versus randomized clinical trials.
Rachel, can you go back to the last study, to the last slide?
Sure.
فهمتوا الموضوع ده? Did you understand this? The last point: low tidal volume ventilation and risk mortality and ventilator-free days with ARDS. What Dr. Rachel was saying is that remember the ethical part in the very beginning of the lecture, ethics, أخلاق. As they continue the study, sometimes, even though it is double-blind and sometimes it is randomized, from time to time, they review the data that's already available, and sometimes the data is so obvious, واضح لدرجة انك بتضر المرضى اللي في الكنترول جروب انك اخلاقيا لازم توقف الدراسة. That ethically you have to stop the study and publish what you have, because the data is already statistically convincing. Okay, that's all I have to say. Just I wanted to make sure that they understood that part.
These large studies, and in fact even small studies where an intervention is performed, what people tend to do is get a data.
What?
Partway through your study, when you may have enough information to what?
We're having some difficulty with your voice, and just the last couple sentences. Yeah. So maybe you can turn yourself around a bit, or get close to the computer.
Yeah, so these large clinical trials and even medium and small size clinical trials, particularly if the intervention is novel, will develop what they call a data safety monitoring plan. And what that generally involves is that at some point partway through the study, somebody who's unrelated to the study looks at the stuff and decides whether there are any adverse events that fall into a pattern that relate to either the intervention or the standard therapy. And if there is a problem with one arm versus the other, then this trial may be stopped. An example of that was the POISE-2 trial, which I was one of the investigators in, looking at aspirin versus placebo. And there was quite a bit of concern early on in the trial that the aspirin patients were having clinically significant bleeding during surgery. So we had a data safety monitoring board that would look at I think at 2,000 patients, they looked at looked at the information. And we were not unblinded, but somebody else was able to look at the data who was having no responsibility for adjudicating the outcomes or right, that we weren't doing stuff to patients that wasn't good for them. So that's kind of the idea. Okay, so an example of looking at one study question that was addressed in two different ways was the topic of estrogen replacement therapy in postmenopausal women. So this is an important therapeutic question, since hormone replacement has a number of physiologic sort of effects on people, but it also applies to billions of women worldwide. There was a combination medication called Prempro that was very popular in the US in the 1990s, and in fact in the 1990s it may have been the most prescribed drug in the United States. It's the question of whether this was good for people has a huge impact on public health. And we know again that estrogen replacement impacts multiple organ systems, including the heart, the vasculature, etc. And there were a number of observational studies done in the 80s and 90s looking at the impact of hormone replacement therapy. And they all made it look like hormone replacement therapy was pretty good. They felt that this was having a decrease of 40 to 80% on coronary heart disease, decreasing bone fractures. There was at some expense of increasing breast cancer and endometrial cancer, but there was the thought that this also may even have positive impact on preventing Alzheimer's disease. So there were lots of observational trials performed, and the results were pretty consistent. But up till about 1996, no randomized control trial had been done. But one that had been a cohort study that was done that was large and very convincing was this one called the Nurses' Health Study, which looked at 48,000 people, and the number of years, almost 10 years, so about 337,000 what they call person years of follow-up, which is a term you often hear in cohort studies. They multiply the number of people by the number of months that they're followed, and found that patients who were using estrogen replacement had a relative risk of about 0.56, so almost half the risk of developing a major coronary disease compared to people who weren't using hormone replacement. So this was really statistically and clinically a significant finding. In fact, in 1997, the New England Journal came out and said that women should all be using hormone replacement therapy after menopause. Now, the reality is that some, although not all, either chose not to do it or didn't get to the doctor to get the prescription or whatever. So there was a subset of women out there who were using hormone replacement, whereas others weren't. And the question was, were these people who were using hormone replacement somehow different from the non-users? Did they have more money, so they went to the doctor? Were they of a different age? Were they different, was their health overall better? Were they more active? Did they have other different health behaviors? And one thing that was always a question is whether these people had better access to medical care than the women who didn't use hormone replacement. So these were studies where it was very difficult to adjust for these possible kind of confusing issues, so that a randomized controlled trial was planned appropriately. Before that, there were even combined analyses of these observational trials, which we call meta-analysis, which are very popular today. And essentially, they're taking a lot of observational studies, combining them together, and trying to get more powerful information from them. And this is the meta-analysis in Arabic. The first randomized controlled trial of estrogen replacement was called the HERS trial. It was started in 1992. They looked at secondary prevention, meaning taking patients who didn't have the disease at the beginning, secondary prevention of cardiac events in people getting hormone replacement or placebo. And they looked at 2,700 women with established heart disease. These were postmenopausal women who were under the age of 80. The mean age was 67. They were looking at 20 clinical centers in the United States. And what they found was no effect of hormone replacement on cardiac events in patients with pre-existing heart disease. No effect. Then the randomized trial included women both with and without heart disease. 16,600 got this combination of estrogen, progesterone versus placebo. And they looked at 40 clinical centers, and the follow-up was planned for 8.5 years. It was supposed to end in 2005. Well, this was a case where the trial was stopped early, as it was found that there was actually a 29% increase in heart disease in women with hormone replacement therapy. And you can see that with that compared to placebo, there was a 29% greater rate of coronary disease, 26% greater incidence of breast cancer, 40% greater stroke risk, and over twofold greater risk of pulmonary embolus. This really changed the recommendation. So the conclusion after the
Rachel, can you go back to the previous slide? Just very briefly introduce the notion, the concept of relative risk, and then of course next lecture we'll talk about it in a lot more detail. Just what's a relative? Just very briefly, that a relative risk of 1 is no change and so forth.
Sure. A relative risk is a relative risk is the risk of an outcome with and without an intervention, in this case hormone replacement therapy. So a risk of a relative risk is going to look at a ratio of the risks in patients who do and don't have hormone replacement therapy. And a relative risk of 1.0 would essentially imply that there was no difference in risk between one group and another. A relative risk of 2 would imply that there is a 2 times greater risk of a problem with the hormone replacement than with placebo. Anything between 1 and 2, you're going to have a certain fraction of increase. So a 1.41 relative risk would mean that there's a 41% greater risk of stroke. Now, on the right, you have the confidence intervals, which we can talk about in greater detail later or tomorrow or whenever. That's giving you sort of the boundaries that that there's a 95% probability that the actual value lies somewhere between these 2 values, level of uncertainty or precision. So to conclude here, the idea is that randomized trials can give much more definitive answers to important clinical questions relating cause and effect, that observational studies can be wrong, and more than that, meta-analysis of multiple observational studies can also get wrong. The bottom line is that confounders, which we'll talk about more in a moment, issues that confuse matters are impossible to fully identify and negotiate in a non-randomized study situation. So it's really important for us to interpret findings from observational studies with caution, particularly when we're making strong questions to people to take medications that may have a very broad impact on their health. So the challenge with the observational studies is going to be, is there a cause and effect relationship? Is there an effect-cause relationship, that being a reverse relationship or merely an association? So if we look, continue down our protocol, we're going to look at the subjects and how we choose the subjects and who we're studying. When you write your protocol, you have to consider who you include in the study and who you're going to exclude.
Is this a good point to have a 5-minute break? We've been at it at almost an hour.
Sure.
Shabab, because this is kind of a nice break point, going back to the chicken and the egg, and then then we'll come back in 5 minutes.
Sure.
8:40 you guys. 9 الا تلت بالضبط. Okay, 8:40. Come back. All right. Meanwhile, if people want to just stick around and ask Dr. Rachel questions, that would be wonderful. Oh yeah, right. It's evening prayer anyway, so they will need, there will be a good 5 minutes to refresh their minds. Yeah, okay. Yeah, I think that's a good idea. Is that okay?
Cool. Yeah.
Yeah. Want to go on Skype for any reason?
Oh.
No,
Yeah,
are we
sure,
good?
whatever.
No, are we good?
Yeah, we're good.
No, that's cool. This is so far going great, and I think so. I hope so. We have accrued instead of if we've had an accrual instead of attrition. So this is cool, man. Yeah, we've had. I don't know if you've been looking. By the way, if you see a pail, look to the right hand to the control panel under chat. If you open the chat box, keep it open, and if it says see.
I can't keep it open because it covers the slide, and then I can't advance the
slide
slide.
it to the right. No, slide it to the right. All the way to the right. And if you see this pale blue thing that says to presenter.
Right, I can't see it.
Yeah, if you see the thing that says to presenter, maybe, yeah. Anyway. All right.
What thing are you speaking
of? Chat. Open the chat. Open the chat box.
Okay.
There'll be a bunch of green stuff. Everything that's green is to the whole audience.
Yeah.
But if you want to talk to a specific person, if it's the presenter, is sky blue. If it's to only one of the attendees, it's pink. You know, I think I'm gonna send a suggestion to Citrix that if you wanna send a specific one, only one of the organizers, if you wanna send a specific message to the speaker, then I think it should be more visible than the sky blue. It should have like pink with stars or something, exploding stars or something like that.
Yeah, I can't actually with that finger. I can't read my slide. It's
really?
too big.
So your slide takes up the whole screen?
Yeah.
It doesn't take the whole screen on my screen. Be darned.
Yeah.
Anyway.
Well, yeah.
It doesn't matter.
I don't know, unless I'm doing something wrong.
No.
Yeah, I don't know.
No, but no. Yeah, you know those the young guys. Derek, remember I talked to you about Derek, the Australian, and he's 32 or something like that.
Yeah.
He's a baby, and My girlfriend says he looks like Hugh Grant, and she has a crush on him. But at any rate, he was yeah, man. Those young guys, they can do 17 different things at the same time. Yeah. But anyway, I couldn't
Oh,
do that. I don't know that I could.
yeah. Well,
Yeah. Yeah. This is going very, very.
yeah. Well, it does. Oh, no, that's good. I don't know. It's hard to tell. I think it is what it is. You kind of just have to give the
Yeah.
facts, I guess. And
No,
I
that's
don't know.
okay.
It's
And
hard
I'll
to know
butt in.
what people already.
I'll just butt in from time to time. If you don't notice the chat, I'll just butt in. I try not to
Sure,
butt in.
sure.
Thanks, by the way, for cutting me off because
Now
I
let
do
me.
tend to ramble on.
Oh, wait a second. Now let me ask something.
Yeah.
Let me. Oh shoot. If I do this
Do it.
now, if you do you see my screen?
Yeah.
You see my screen?
Yeah. Yeah.
You
Yeah.
do. Okay.
Will
Do
do.
you see just the presentation, or do you see?
I do not
Okay,
see
that's
the box.
interesting.
I do not see your notes box, your speaker's notes.
No, I don't. I'm not looking at them. I don't have them. I just was wondering though, because I just this is just yeah. It just takes up too the box is. I just want to make the box smaller, not minimal. But they don't let you. It's either big or it's gone. It, I don't understand why that is.
Well,
Uh,
you need to. Well, yeah, I sort of. I don't know, man. I just do the. I do the little thing on the bottom there, the TV thing on the bottom, yeah, and this is what I get. Exactly. This is what I get.
well, I don't know, but I mean, I don't get it. I mean, are you saying that if you have a PowerPoint presentation, you can see the entire every square inch of the slide with that box open?
Yeah, this one here that you're showing me, absolutely,
Yeah,
very clear, as clear
yeah,
as the bell. Yeah,
I don't.
yeah, yeah, yeah.
I
No,
see
that's good.
I see about 2/3 of the slide.
Hmm.
Yeah, no, I see about 2/3 of it.
Oh no, I see all of it, including the
No,
logo and everything.
it's covered. You
Yeah,
see the entire right margin of your slide.
yeah.
See, I
And
think maybe it's a formatting thing.
I don't know. I
There's a
don't know.
formatting thing.
I've
Yeah,
yeah, yeah.
I
I've
think it's
had
very.
I did a few experiments with Terry, but of course she's on the same download speed as I am. So yeah, she's never had any problems. But anyway,
I have to put the control panel way down at the bottom off my screen so that I can see my slide.
yeah.
Yeah, I don't know
Well,
why
I'll
that
tell you
is.
what, we're coming up on we're 3 minutes, but they pray the sundown prayer, so it'll be a couple more minutes. So I'll be right back. Okay.
Okay.
Richard,
Yes,
I have a question.
sure.
When we read the study, how can we know that if it's strong, if it's weak, if we can convince in it, if it's wrong?
It's a great question. I think I think for one is to go through and try to figure out if the authors were straightforward about their methodology. That is, I think if they describe not only how they did the study, but why they did it the way they did it, if they talk about the design. So I think you have to decide if the research question is important. It's trivial, and there are a lot of really nicely constructed studies out there that were done really well, but I, I, I personally can't see a lot of impact that it would have on clinical care. So I think there are a number of things of that sort. And then, you know, you get, I will say this, you can't always tell whether somebody has, whether data are valid. I think that in fact, over the last 5 years or so, we've had several very prominent investigators who have been disciplined for possible commission of research fraud. So, and it wasn't easy for the editors of journals to figure this out until a lot later on. So I think you're raising a point that's a good one. I think that you have to decide how, you know, assuming that things are done honestly and ethically, then you have to decide whether what the strength of the evidence is, and whether there are other possible reasons that the findings were what they were. And we're going to talk more about that when we talk about confounding. Confounding is one really big problem, mostly with observational studies, but also it can be a problem with randomized trials. And so you want to try to, you know, look at a lot of existing studies and see what's, you know, where things have fallen down, and you get an eye for it. And then you ask yourself, well, you get a little skeptical about the findings, but it takes a little while to get an idea of where things may have, you know, things where they may have found, you know, underpowered a study, not put enough patients in, etc. You know, not look for the right outcome. How the outcome was measured may be faulty, etc.
Okay,
but yeah,
another
that's
question.
A big problem. Yes.
When we did a study, how can we decide which name of the doctor we can write it in the study as the participator? Or the doctor who did the study, or only the head manager, or one who decides who did the study?
Yeah, good question. Authorship. Yeah, that's a really good question. I mean, who's going to be on who the author is going to be? Well, I'll tell you one thing. The old-fashioned way was that your head of the department was always an author on the paper. Nowadays, more of the journals are asking you to specify exactly what each author did, and one of the right answers isn't, well, I was chairman of the department. That doesn't fly for most journals anymore. Some journals don't ask for this, for you to, you know, to spell it out, but you know, they want you to say things like, you know, he was the principal author, was the person who composed the study protocol, and you know, say collected data, or you know, helped with manuscript preparation, or did some data analysis. All of these particular things are legitimate things on which you can be an author. Now, if you want to decide who's going to be the first author, and that's usually the person who, one of two things are true. It's the person who came up with the idea for the study and did most of the work is usually the first author. If you have two people who did a lot of work, say you and a research mentor, or, you know, if you're a junior person and you have a research mentor, then often the junior person is the first author and the senior person is the last author, because last authorship is also very is prestigious. And then your other people who may maybe you're a postgraduate student, or a, you know, a medical student who's helping you with collect the data, maybe a middle author, etc. Or a statistician who may help you with, which I recommend, if you can, always have your protocol at least reviewed with a statistician. And that sometimes that person may want to be a co-author. Sometimes they'll just say, I'll help you for an hour, and, you know, whatever. They don't necessarily need to be a co-author, depending on their level of involvement and interest. But I think deciding in advance who's going to be an author and what position author is a good idea. Sometimes it's a little difficult to talk about, but I think it's worth doing. Everybody has these discussions at some point along the way.
Okay, another questions before we start?
Go ahead.
When we published the paper, the problem that I faced
Absolutely.
is that you are limited with the number of the words that you need to write it. So how we can overcome this problem, especially when you need to publish it in any journal? They told you need only 205 words. You need only to have a published paper with 500 words. It's crazy.
It's a great, yeah, it's hard. I agree with you. I once had to write a 250, I can't remember, 15-word abstract or something, and it sounded, it got so boiled down, it was so terse. I think there are two options. I mean, one is that you make your language very compact and contracted, or you
راح الصوت خالص. Rachel,
يا
can you
خسارة يا
hear me?
خسارة.
اسمع بس. Rachel, can you hear us?
say less.
Rachel, you disappeared for about
You're
15
having
seconds.
so much, yeah.
You disappeared. Your voice disappeared completely for about 15 seconds. Is there a way?
Oh, okay. Well,
how about that table? You know that table, that handy dandy table you have in your room. Can you bring it close to the door and sit at a chair by the door with the table? Because that brings you a couple feet closer to the modem in the hallway. Maybe, I don't know. Maybe it will work.
let me try to let me move around the room a little bit.
Yeah.
Hang on. Actually, it's going to be farther from the door because the door is farther away from the modem. So let me move closer to the window.
Yeah.
Yeah, let me try that. Okay. How's this?
Oh, this is
Is that
wonderful.
better?
Oh, this is nice. Yeah. سامع يا مجدي؟
Is that better?
مجدي سامعها؟
Yes, yes, of course, it's wonderful now.
Okay, good. Okay.
Okay. Yeah, I think that getting things into a small size is a problem, can be a problem. You know, the other thing is that sometimes if you're submitting something, say for to be reviewed for a journal in a different language, like, so it's not your primary language, which is, you know, is a condition most people have to face. Sometimes if you just get some input from a native English speaking author, they can find ways to trim up what you're saying to fewer words, and sometimes that helps, sometimes it doesn't. But I've noticed sometimes if I've gone through something with somebody who's, you know, say some French colleagues, let's say, who are submitting something to an English language journal, you can really sort of tighten it up a little bit so that it will fit within the guidelines, but it's not easy sometimes.
Magdi, I tell you what.
What?
I'm sure maybe in the future, as we start doing more and more studies, we'll have to have an actual editing committee. But for now, just write your abstract, send it to me, and I will send it to be it Dr. Rachel, Dr. Franco, Dr. Brendan Finucane, any of these people who have written thousands of abstracts, and I have written dozens, not thousands, and we can reduce it nicely to what's required. That's not a problem. Don't worry about it.
Yeah, I think that's if you have a good idea and you did a good study, then I think getting it to fit in, it's not that it's easy, but I think that should be ought to be able to be overcome. You know.
That's what I did. I sent the study to Dr. Brandon, and he reviewed and decreased a lot of words.
Yes.
Yeah. Perfect.
Yeah, that's why you have a family, Magdi. Now, I'd like to make this whole thing into a family, and I'd like, after people go home, to continue to participate through Facebook. We have a 27-year-old man who invented this wonderful thing called Facebook, and Yeah, we can all talk to each other on it. And
Yeah.
we can even send the private messages without anybody having access to them. Okay, is everyone back? Is everyone back? صليتوا
I'm still
استحميتوا؟
away.
Huh?
I'm still away. I'm joking.
Okay. All right, Miss Rachel. Let's go back. Let's go back. I would. Do you want to? Can I suggest that we go back to
Yes.
the chicken and egg?
Yes. Okay. Yes. So we'll talk. We were talking about the difference between randomized controlled trials and observational studies, and the main uh, strength of a randomized trial is that it's really the best and only way to establish cause and effect rather than just an association between one variable and an outcome. So frequently with observational studies, we can get a pretty good idea, but there's always going to be some um, room for doubt. So if we want to consider who we're studying and how we're going to choose these people, this is very important for whether we're going to have a successful research study or not. You have to think about who we're going to include, what are the inclusion criteria, and these need to be broad enough so that the findings are going to be of interest to others, but we're going to have to make them narrow enough so that we decrease the variability in our subjects. So, for example, if we want to look at some kind of impact on use of opiates in surgery in general, if we just studied all kinds of surgery and included thoracotomies and laparotomies and laparoscopic surgery and hernia repair, it would be very difficult to make conclusions because of the large variability in types of patients. Instead, if we restrict our study to patients getting knee replacements or shoulder arthroplasty, etc., then that narrowing down can actually help us get a better idea of the just to focus on the intervention and the outcome without considering that you have all kinds of different types of patients. Advantages of studying a narrowly defined group are going to be not only the decrease in variability, but also a decrease in cost. The disadvantage of studying a narrowly defined group is that it's less likely that the study findings will be true for people in other parts of the world or who are getting other kinds of care. So it's less generalizable and it may be a little bit less interesting to others. One set of patients who have, for example, been typically excluded from studies are patients with chronic kidney disease and kidney failure. And this has often been defended by saying that, well, those patients are so different. They don't. They have a whole host of physical problems that may confound or may confuse the meaning of an outcome. But in fact, what's happened is that this has been very harmful to patients with kidney failure because they, if a group of patients is consistently excluded from randomized trials, they don't benefit from this growth in medical knowledge. So this has been a problem for a lot of particular groups. It's been a problem for female patients. It's been a problem for patients in developing countries and in patients for particular diseases that have been excluded because investigators just kind of didn't want to include them because they were concerned that it would complicate the data. So it's just something to think about. There's a trade-off between having too broad a subject population and having too narrow a population where you're going to exclude patients from benefiting from your findings. So what measurements are we really going to make when we do these studies? We have to think about these things, and there are really three categories of variables. There are the predictors, which are going to be what we also call the independent variable, and this is a variable you've chosen and you can manipulate. And the study will attempt to understand the relationship of this predictor to your outcome. And it's best chosen if there's some kind of biologically likely impact it will have. So you have to think about what we call biological plausibility. And so you don't want to just pull things out of the sky at random, but things that would be, that it might be reasonable to suspect may have an impact. Our outcome variable is also called a dependent variable, and it's really called that because it depends on the predictor. It's the clinical endpoint of interest, examples being stroke, heart attack, death, length of stay, opioid use, etc. A confounding variable is one that can get in the way. It is the word confounding comes from confusion, and it actually can confuse your findings. This is going to be an element that has a relationship both with the predictor variable and the outcome variable. In certain cases, actually may have a stronger cause or be the real cause or actual cause of the outcome, and instead of the predictor variable that you chose in the experiment. So if this is not recognized and controlled in the beginning, this confounder may damage the validity of your experiment. And this is sort of pictorially what the confounder is. It has an independent, its very own relationship with your predictor or exposure and your outcome or your disease. And so it may do several things to the process. Here's first an example of confounding. Investigators were interested in looking at the impact of alcohol use on the development of ischemic heart disease. And there was some indication that alcohol may be associated or cause ischemic heart disease. What people didn't initially think about was that one thing that's also very highly associated with alcohol consumption is cigarette smoking. So if people, when they have a drink, pick up a cigarette as well, that this may actually be the stronger influence on ischemic heart disease, which is known experimentally by numerous types of data, by animal data, by preclinical data, etc. So, and by big epidemiologic studies. So it would be likely to say that the alcohol, that smoking is the confounder here for ischemic heart disease when you're looking at the relationship of alcohol to ischemic heart disease. A sort of commonplace, sort of funny example is one where which asks, can being married actually cause you to have cancer? And this would go something like this. If you have two hospitals, Hospital A and Hospital B, Hospital A is a general hospital where all kinds of various disorders are treated. Hospital B is a cancer hospital. And Hospital A, it turns out, has 50% fewer married people in it than Hospital B. So then that would lead people to ask, does being married actually cause cancer? Now the confounder would be the fact that people, when they are married, are able to receive care at home rather than in the hospital. And the patients who are in the non-cancer hospital, so the non-cancer patients, are able to receive care at home if there's a spouse in the house and the physician can visit them there. Cancer patients require care that can only be given in the hospital, whether it's radiation or chemotherapy, and so have to stay in the hospital regardless of their marital status or the presence of any social support in the home. So if you looked at it this way and diagrammed it, the question would be, does marital status influence cancer? And being in the cancer hospital versus being in the general hospital, and the initial findings would suggest yes, but what people then had to realize was that being married was influential on the ability to receive care at home, and that being able to receive care at home really only helped patients who get out of the general hospital and not the cancer hospital. So this is an illustration of a confounder. Married people are able to get care at home. Cancer patients must be hospitalized regardless of home care. Ability of married non-cancer patients to get care is the confounder. So the confounder is a condition that has an independent relationship, again, both with the predictor and outcome variables. And it can do one of two things. It can hide a true relationship of cause and effect between a predictor and outcome variable, or it can actually suggest a false relationship of cause and effect between two variables when it doesn't really exist. And here are two examples of each. Suppose we're interested in looking at the level of exercise and physical activity and impact on bone density in elderly patients. So we ask experimentally whether there's a relationship here between one and the other. What we have to consider is that body weight is directly related to bone density. So the heavier people have denser bones. Now there also is, as we can only guess, an inverse relationship between amount of exercise and physical activity and body weight. So this relationship, this inverse relationship between these two predictors may actually hide a relationship. So the impact of exercise on bone density will be unrecognized and hidden unless we control for the contribution of body weight to bone density. So in fact, when we control these variables, we find that the level of physical activity, in fact, is correlated with bone density, but you have to first factor in the different weights of the patients. Another one would be the hormone replacement therapy. If an individual takes hormone replacement therapy in an observational trial, that appeared to actually decrease the risk of adverse cardiovascular outcomes. Well, what we didn't think about was that the choice to have hormone replacement therapy is made by a specific kind of patient, and one who's presumably more physically active and concerned about bone density, one who's more educated and has more affluent, has better access to medical care. All of those issues are going to be factors that will tend to decrease an individual's risk of adverse health outcomes, including coronary disease. So another would be the observation that etomidate may increase the risk of dying in the hospital. What we also know, because we're anesthesiologists, is that the choice to give a patient etomidate instead of propofol or pentothal may indicate that the patient has cardiovascular disease or is hemodynamically unstable. And wouldn't it make more sense to say that the hemodynamic instability contributed to the risk of dying in the hospital and not the drug itself? Although we know this is speculation, but this is a reasonable question to ask. So how do you minimize this confounding? One way is to really read and understand your subject area well before you design your study, and identify and measure all of these possibly relevant variables, and then consider their relationship between the variables. For example, does one cause the other? Does one mediate the other? And the converse as well. And then you include all of these possibly relevant variables into a multiple regression model and examine the impact of multiple factors altogether on the outcome of interest. We'll talk about how to do this shortly. Or you can actually consider performing a randomized controlled trial. Again, you have to be careful about having equal groups and to randomize blindly, but if you're doing an observational study, it's really important to consider all of the possible relevant factors and how they would relate. So statistical issues. This is where a lot of research gets a little bit more tricky. What tests must be passed? How do we determine how many subjects we need to study? And what kind of analytical methods are we going to use to determine whether we've answered the research question? First, a hypothesis has to be stated in advance, unless you're planning to do a purely descriptive study, and then no hypothesis is needed. But a hypothesis is a kind of research question, and it's phrased in such a way that the main elements of the study are summarized. So you list what are our predictor variable or variables, what are our outcome variable or variables, and you define the study subjects. And then you make this the basis for calculating the statistical significance and sample size. And the statistical significance essentially is the probability that your research findings could have occurred by just by random chance alone, and the probability that you're going to be able to answer your research question with the methods and number of subjects that you're going to recruit and study. So the hypothesis is stated in two forms. First, there's a null hypothesis, and that is sort of a scenario that goes something like this, saying there's no association between the predictor and the outcome. So there's no association between alcohol use and liver cancer in middle-aged and elderly 50 to 80-year-old men in Tasmania. It's a very narrow subject, but you're being very specific about what you're asking. Then you state an alternative hypothesis, and you say there is an association between alcohol use and liver cancer in these 50 to 80-year-old men in Tasmania. Your alternative hypothesis can be stated one of two ways. A one-sided statement would state the direction in which something would differ. So you could say alcohol use increases liver cancer in 50 to 80-year-old Tasmanian men. A two-sided alternative hypothesis does not state the direction. It merely states that there's a difference. So an example being there is an association between alcohol and liver cancer. It could be positively or negatively correlated. When you're using these null and alternative hypotheses for sample size calculation, you should almost always make it what's called a two-sided alternative hypothesis for this. This is kind of a humorous example of a null and alternative hypothesis. We all have done laundry. We've all suffered when we can't find one of the socks. This happens more often than we want to admit. So you decide you want to figure this out. The null hypothesis here would be aliens are not to blame for my missing socks. There is some other explanation for my socks being missing. The alternative hypothesis might state extraterrestrials have invaded my house in order to steal my socks. This would be sort of a humorous thing, but what the null hypothesis really is a statement made indicating lack of difference between groups at the outset, and it's assumed for the sake of argument and for the study design, it's assumed to be true. That statement then is refuted or proven false by performing the statistical tests on the study findings. The results are evaluated with what's called a p-value, and a p-value that is sufficiently small indicates statistical significance of the finding and will then allow us to reject the null hypothesis. The statistical significance, the level of significance for rejecting the null hypothesis is considered the level of significance. It's the probability that the null hypothesis will be incorrectly rejected and that the alternative hypothesis will be incorrectly accepted. And we set this with a value known as alpha. And we usually set this alpha conventionally to be 0.05, meaning we accept a 5% or less false positive rate. This is, of course, sort of an arbitrary number, and alpha can be set lower if we wish, or higher. The power of a study is the probability of being able to accept the alternative hypothesis if a true association exists. And the term known as beta is really the inverse of power. It's 1 minus beta is the power of the study. And in words, what that means is the power gives you the likelihood of being able to reject the null hypothesis if the alternative is true. And conventionally, we set that number to be 80 or 90%. A type 1 error is something that occurs when we erroneously accept the alternative hypothesis, and alpha is the probability of making a type 1 error. A type 2 error is erroneous rejection of the alternative hypothesis. That is, there really was a difference in the groups, and we just weren't able to find it. So how do we express the statistical significance of a finding? We do so with this p-value. Again, it's the probability of seeing an effect as large or larger than we actually found in the study if such a difference in groups really exists. A statistically significant finding will have a p-value less than or equal to the alpha that we said at the beginning. So as an example, a p-value equal to 0.03 means that there is a 3% chance that the findings suggesting that aliens stole your socks are erroneous. So if we look at this 2x2 table, up here in the blue would be considered the reality of the situation if you had a gold standard way of determining it. The null hypothesis here is true or false. If it's true, meaning that the aliens didn't steal your socks, but you then reject the null hypothesis, you've made a type 1 error. You've incorrectly rejected the null hypothesis, and you conclude that the aliens took your socks. So you don't want to you do not want to commit one of these. People do. The converse would be if the null hypothesis is true, and you fail to reject the null hypothesis, you've made the right decision. If the null hypothesis is false, that is, your alternative is correct, and you do reject the null, you've made the right decision. If you fail to reject the null hypothesis, even though it's false and your alternative hypothesis is true, now you've committed a type 2 error. It's incorrect acceptance of the null hypothesis. So an example would be you conclude that aspirin does not differ from placebo in preventing thrombosis of coronary stents, something like this. You weren't able to prove it. That's a type 2 error. How do you experimentally reduce the chance of these kinds of errors? With a type 1 error, one thing you can do is manipulate that alpha number. You can make alpha smaller. So you can always make alpha 0.025, you can make it 0.01. So that's one way to do it. Another way is to increase the precision of the measurements that you're making if possible. You can narrow your inclusion criteria, and the way to prevent the type 2 error is really just to increase your sample size. So let's talk a little bit about what kind of measurement we'll be making and what the issues will be in each case. There are basically two kinds. There are categorical measurements and there are continuous measurements. Categorical measurements are ones where there are not ranked values with definable intervals between each value. So a dichotomous a measurement would be sort of either it would be a yes or no, red or green, black or white. Examples are a patient lived or died, had a bad outcome or didn't have the bad outcome, and you express these as counts or proportions. Nominal measurements are named. Nominal means named. So these are unordered categories, things like blood group, ABO, gender, male, female, and again, those are sort of expressed by counts or proportions. Now, ordinal data are ones where there are ordered categories, although there are no defined, measurable, meaningful intervals between each measurement. So examples are going to be ASA status. We can say that 2 is higher than 1, but we can't say that 3 is twice as big as 2. In other words, the scale is ordered, but it's not. There's no magnitude to the scale. VAS pain scales do not have discrete definable intervals. And if you call something low, medium, or high complexity again.
Thank you. A little closer to the microphone.
Okay. If you call something low, medium, or high complexity, etc., that's an ordinal scale, but it's not. The intervals between the various levels are not definable or interpretable. Those measurements can be looked at with counts or proportions, but are also often defined with things like medians and percentiles of who falls into which order. The data that are a lot richer and to use are continuous data, and these are ranked values with quantifiable intervals. And examples here would be body mass index, troponin values, blood pressure, heart rate, glomerular filtration rates, BNP values, hematocrits. and these are usually normally distributed in populations and are expressed as means with standard deviations, sometimes with medians and percentiles, if depending on the distribution of the data. And we'll talk about what that means in a minute. So how do we describe and organize a set of numerical observations? And what are the measures of central tendency and the distribution of the values? And how does knowing this information help us? If we're looking at measures of central tendency, one very useful one is the median, also known as the middle value. The 50th percentile value, where half the other values lie above and the other half below. And it's appropriate to express the median when we're using ordinal scales, or when continuous data are not distributed in a normal manner, and we'll talk about what that means next. We also talk about the mean, which is also known as the average, and all that means is that it's the sum of all the observed values divided by the number of observations. And we use the mean when we have what we call normally distributed data. And normal distribution would be something like this. If you took all of your findings, all your observations, and down here on this axis you have increasingly greater size or magnitude of a measurement, and on the y-axis you're going to have frequency density, your data will fall into the shape of a symmetric bell. We call it the bell-shaped curve, where on either side of the mean here you've got fairly symmetric findings. You'll also notice that your mean and your median are the same. So biological data are often normally distributed, and these include things like the shoe size in adults, the hematocrit, the head circumference in babies, height. All these things tend to be normally distributed, and the median and the mean are roughly the same when you see normally distributed values. So the bell-shaped curve also has there's a standard deviation, and what the standard deviation describes what proportion of the values fall within a certain distance from the mean, and it's the standard deviation is the square root of the variance, and it describes really the scatter around the mean, how tightly all of the other data points tend to cluster around this mean value. By a rule of thumb, 68% of your values are going to be lying here one standard deviation above and below your mean. That's where 68% of your people are going to live here. If you are interested in 2 standard deviations, then 96% of your people are going to be plus or minus 2 standard deviations, and then when you get to 3, it's almost everybody. Just about everybody lies between 3 standard deviations of your mean. So how you do this first is to determine the variance. And here's just a very kind of simplified example of how this is done. You really do it with you can do it with Excel or a statistical program, but if you wanted to do it with a pen and paper, which I encourage, here's how it would be done. You take, if these are 8 values you have, your 8 observations, you sum them up and divide them by the number here, and you get an average of 5. And so to get the variance, what you're going to do is subtract each of these values. You'll subtract 5 from all of these values and square them so that you get a positive number. And then you sum all these squares, divide by the number of observations, and sometimes you can subtract 1 from the number of observations to give yourself a little penalty. And then you take the square root of this, and that is your standard deviation. So it just gives you an idea of how closely your observed values tend to cluster around that mean. And here's just in kind of a visual of 3 data sets. They all have the same mean, but they have very, very different standard deviations. And you can see that the dark blue one has a standard deviation of 5. Data are clustered very close to the mean. This orange one here has very broad, very broad scatter of data. Both are normally distributed though, and knowing that the data are distributed in such a way is powerful in that that standard deviation is useful. So an example is, suppose you're studying a new inhaled anesthetic, it's not yet on the market, and somebody's come to you and said, you know, doctor, can you help us figure out how to use this, and we want to make sure it works on patients and it doesn't, you know, people don't wake up in the middle of surgery and know what's going on. So you need to decide whether this is going to provide reliable anesthesia and amnesia for patients who are going to have surgery. So how are you going to go about doing this, and how will you determine whether it's effective, and it's so at what dose? You want to find the amount which is enough to put, you know, almost everybody, keep everybody asleep, but you don't want to use too much. So the clinically relevant questions would be how much anesthesia is needed to ensure amnesia. So what you'll need to do is first define a dose aware, meaning the mean in-tidal concentration where at least 50% of your subjects don't demonstrate learning or recall while receiving your anesthetic. And these studies have actually been done in people, in human volunteers. People are put to sleep, they're given various amounts of anesthesia, they're being told various things, and then they're awoken and asked to recall what's been told. So this is certainly not the same as remembering things during surgery, but this is how a lot of these studies were done. So what you'll do is collect the distribution of in-tidal anesthetic values that are equal or greater to the values where the subject didn't recall things they were experienced or were told during this experimental anesthetic. Then what you want to do is graphically look at the distribution of all these values and verify the shape of the distribution that it's normal. And then from that, you know now how to determine the variance and the standard deviation. And at 3 or 4 standard deviations above this mean dose aware, we know because of the properties of standard deviations that it's very unlikely to find people getting intraoperative awareness and recall if you push it out to that high a value. So the question is, how would you test and verify this? So again, here you would plot your values. These would be ranges of in-tidal anesthetic above which the subjects didn't learn or remember. You calculate the mean, the variance, and then from that the standard deviation. And we know that roughly 99% of values are going to lie within 3 standard deviations of the mean because that's how it's defined. Then the questions that you would ask yourself were, how many observations do you need to make to determine the dose-aware values? And that goes to sample size. What was the precision of the measurements? So you want to make really good and sure that you're making the measurements correctly, the in-tidal anesthetic, and also how are you measuring the awareness and recall? These are important questions that we assume are simple, and they're actually not as simple as we'd think. So it's important to have very reliable, precise scales. Then another valid question is, this may be true of research subjects, but are research subjects really similar to patients? I mean, patients presumably are sick, they're having surgery, so this is, excuse me, a different condition. So is the assumption valid that equating learning what you're told during the process of a study is similar to becoming aware that you're having surgery on your body and that you're in an operating room and supposed to be asleep and you aren't? Then when anything like this is done, you also want to look around and see if there is preclinical data from animals, for example, supporting a threshold effect for anesthetics, and to also see if there are some biological correlations. For example, are there EEG findings that may change at a certain level that would be sort of supportive of the idea that no learning or so forth could take place? And then, of course, to look at findings from other investigators too. It's always helpful to see whether there are similar findings, or in fact, if there are contradictory findings, that would make us go back and question this, because it's these are, as you can see, these are very critical questions that that have great impact on our profession, on patient safety and welfare, and the marketing of a new drug. So with this, so I'm going to stop and see if there are questions, and we're going to continue this discussion in greater depth tomorrow.
Rachel, can you go back to the standard deviation definition slide that I had in Arabic? Because I think for some reason it got... There you go. Here's the standard deviation. Okay, I'll give you a couple minutes, 2 minutes to look at in Arabic. Excuse me. Oh my God. الانحراف المعياري. And I just want you, that's the standard deviation that Dr. Rachel was talking about. I just have it, in Arabic as a definition if you want to take a screenshot of this. And then Rachel, do you mind just after we spend another 30 seconds on this slide just for them to read it in Arabic, do you mind if you
Sure.
explain what the standard deviation is on your bell curve, Gaussian curve? Just to make sure that this notion is extremely important. Standard deviation, you'll see it in every paper, in every paper you read, and you need to understand الانحراف المعياري. standard deviation standard deviation في أطباء فلسطين مثلا، في الناس اللي زي محمد حجازي ورعد بيصل إلى المترين والبعض متر ونص. فالانحراف المعياري هيكون كبير. فلو قسمت مجرد قسمت طولهم مجموع أطوالهم على عددهم راح أعطي لك رقم طبعا متوسط، لكن هذا المتوسط بيتراوح بين مترين ومتر ونص. ف الستاندرد ديفيشن حوالين المين، اوكي، حوالين المتوسط الحسابي بتقلل مصداقية المتوسط الحسابي. Okay, I hope that they have had enough time to read this in Arabic. And now, if you wanna just go forward to your bell curve, yeah.
Hafiz.
Yes.
Yeah.
Excuse me, I will ask Dr. Hafiz in Arabic. So
That's okay.
please.
That's okay. Whatever. Any language, anything.
يعني دكتور، يعني كل ما زاد الرقم بعدا يعني عن الوسيط هذا بتصير خطأ القراءة ولا كيف؟
لا، اسمع standard deviation معناها ايه؟ Can you go Rachel, can you go back 1 2 3 4 5 okay. شايف الاسهم السوداء اللي على الشمال وعلى اليمين؟ هاي الستاندرد ديفيشن. افرض فرضا خدنا اطوال قسنا اطوال الاطباء اللي في فلسطين، اوكي، في منهم هيوصل مترين، وفي منهم هيوصل متر ونص، وفي منهم مثل جراح عام في مستشفاك انت اقل من متر ونص. اوكي.
مدير مستشفى
مدير المستشفى هو مدير مستشفى هلا. Well, what I'm saying is if you're just so you can be following, I said let's take the height of all the doctors in Palestine. Some are extremely tall, some are 6'9", 2 meters tall, and there is a gentleman who is just a delightful gentleman that you will meet next week in Hebron, by the way. He's a general surgeon. He's a tiny little thing who weighs 90 pounds, and he's probably about 4'9". And so if we took the standard deviation of all the doctors in Palestine, the standard deviation will be very wide because it takes into account the height of everyone, and it takes the bell-shaped distribution
Yeah.
curve. And in an attempt to explain
Mm-hmm.
the importance of the standard deviation, that the greater the standard deviation from a mean, from a statistical mean, okay, المتوسط الحسابي, the average, if you will, that would give more credibility and more importance to also knowing the median, because the median will be closer either to the short or to the high. So what you need to do, yeah, is simply to understand the mathematical concept of the standard deviation, because you will see this in a lot of papers talking about a
Mm-hmm.
standard deviation, and you need to understand what a standard deviation means. And I'd like maybe Dr. Rachel can explain a little bit more about the standard deviation, because they'll see a lot of this in papers, and when we're doing papers in the journal clubs, we'll see a lot of that. And I'd like to have you give them, emphasize the definition, if you will repeat the definition of standard deviation so everybody knows exactly.
Sure. The standard deviation is going to be directly related to the variance, meaning the distance of all of the observed values, how tightly those observed values tend to cluster close to or far away from the mean, and that the variance is obtained by essentially the sum of squares of distance between each observed value from the mean, and it gives you an idea of how much of your, what percent of your entire observed values lie within a certain distance of the mean. And we can say that plus or minus one standard deviation will sort of encompass about 68% of your observed values. So if you say that let's say the mean height of doctors in Palestine would be, oh, I don't know, let's just say it's 60, 68, 69 inches. Your standard deviation is going to be plus or minus a value that will encompass about 68% of your doctors. So if that's going to be plus or minus, I don't know, 5 inches, let's say, that sounds about right to me, would be a standard deviation. But you only know this by actually measuring them. Now you may have some outliers. Dr. Heff has described an outlier that may you may have, so not all data in sort of smaller populations are normally distributed. I'm not saying Palestine is small, but if you if you take the world population of doctors, I think it's very fair to say that that's normally distributed. So that's one of the advantages of doing a large study, is that it tends to soften the impact of these outliers, because if you study enough people, that the effect tends to go away. Now, not all data are going to be normally distributed, and then here's one famous example of non-normally distributed values, and that's income in the world. Income is not normally distributed. It is very skewed. So you're not going to have a shape of a nice where most people have sort of an average amount. There are going to be most people are like this, and then it's going to trail way. It's going to be what they call right skewed. So adding more observations doesn't always ensure normality of a distribution. So it's not that's not a good example. Income would not be a good example. I don't know if that helps.
As long,
but it does help you make inferences about if you have value. Oops, I'm getting it does help you make inferences about what the data mean, and how many you know, how sure you need to be about things. For example, that.
Is that you?
So, yeah.
Okay. Anyway, all right. So, yeah, you understand, and you all understand
So tomorrow I was going to go over.
the importance. Sorry, just hold on for a second. The importance of knowing the standard deviation. Today, you're not going to be an expert. You're not going to become an expert on standard deviation, but at least you started to understand the notion and the concept of standard deviation. And tomorrow you'll understand more, and maybe if you go Sunday, you'll understand even more. And you know, when you read a book, you'll understand even more. So anyway,
طيب دكتور حافظ.
yes,
Yeah. Tomorrow we'll go.
you can answer your question in English and see what happens.
Okay, what I'm gonna ask is, if I have seen one study and it's written beside it that it is the values is one standard deviation, that it means the whole study is talking about 68% of the people who were being under investigation.
Rachel?
So it depends on what you're saying. You know, what exactly you saw that said plus or minus a standard deviation. If you saw, say, a value of something, or what was how is standard deviation used? Well, I'll actually sort of answer my own question. If you see something like, you can say it took 5 minutes plus or minus 1, 5 plus or minus 1 minute for a patient to wake up after the anesthetic was discontinued. What that means is that 68% of the people, in 68% of subjects, waking up took between 4 and 6 minutes.
Mm-hmm.
If you're talking about a standard deviation of 1, so that would mean an interval between 2, you know, plus or minus 1 from the mean, if the data were normally distributed. Now, not all authors will tell you whether their data were normally distributed if they don't put a graph in. Some data you can assume are probably normally distributed, but it's not always a fair assumption. So a lot of times it's more reasonable to try to look at something graphically to see whether in fact they were things were normally distributed.
Okay, that's all.
Okay, questions. So if the standard deviation and the mean are at the same number, that means the study will be stronger than the study where there's the standard deviation and the mean slightly differ away from each other.
Ask that again, sorry.
Majdi, ask your
Have a study and the standard deviation and the mean are at the same number.
Oh, if the mean and the standard deviation are the same?
That means it is stronger than? Yeah.
Well, sometimes you see very large standard deviations in a value, and you know, that's not always necessarily, that's neither good nor bad. I guess it depends on what you're trying to say, and it would tell you that the measurement is not very precise. Now, one thing that is interesting is that, going back to anesthetics, because I guess I'm an anesthesiologist and so forth, is that if you look at the standard deviation of something like a Mcaky, like the amount of the end-tidal anesthetic concentration where 50% of subjects don't move when they have an incision is made, that value actually has a very small standard deviation, and so Mcaky is a useful concept for us to use clinically. But you know, if a value has a very broad standard deviation, that may mean that the you know, it's not very precise. But it doesn't necessarily, knowing that is not necessarily good or bad. But I think I would sort of interpret it very literally to say that it's just not it's a broadly, it's kind of like this this orange data here. That's got a huge standard deviation. You know, it's fair to say. I mean, I think that sometimes the data are what they are, and it doesn't necessarily mean that the study was bad. It may mean that the statement made is not as strong. You can't make as strong a statement by predicting that you're going to get that value again in the future. But if you have something like this blue distribution, that's pretty, there's a lot more reproducibility and reliability. But I don't know.
The smallest.
Sometimes you just have to describe what you get.
Do you agree that the smallest standard deviation in the world would be how many eyes humans have? Because 99.99999% of them have 2 eyes and 2 ears.
It won't be a bell-shaped curve.
You will get a line.
Not a bell-shaped.
Bell-shaped curve. Blue one.
Binomial distribution. That's a different distribution. It has a different statistical. There's a different sort of test of statistics for that. That's a binomial distribution. I understand,
but let's just say to have fun that we are going to do a Gaussian curve. اسمه هاي منحنى جاوس بالمناسبة. Gaussian curve, bell-shaped curve. Let's just say count all the people in the world, how many noses they have. Everyone will have 1 nose. Maybe 1 in 7 billion will have 2 noses. But, so the standard deviation will be 0 in this case. It's not that now the mean will be 1. The standard deviation will be 0. Now let's see eyes. How many people have 2 eyes? Oh, well then the mean will be 2. And the standard deviation will be 0.00000000001, because there may be 1 or 2 people. If you've seen the film Harold and Kumar, there are people who have only 1 eye, but they're inbred son in the basement anyway. If you start looking at how many arms people have, well, then you'll have a little bit of a bell curve, because the standard deviation will be 0.00001. That's it. Because some people have 1 arm. And so on. And you go on like this. The Mac is a little bit bigger, and then and so on and so on. Well, so
but I think that what you want to do is look at it again at the type of data we had, and I think we go back to sorry for jumping here. We go back to these kind of measurements we're making. The kinds of measurements where we tend to see normal distribution are these continuous ones, where there are ranked values with quantifiable intervals, and I think your point is that there are sometimes broad standard deviations, but it doesn't necessarily mean that the measurement wasn't valid. I think that a lot of times, if you consider that it's just that is the way that something happens in nature. It doesn't,
But I think what Dr. Rachel's main message, and correct me if I'm wrong, Rachel, I'm just interpreting it for you, and I'm trying to do this in slow English, is that the bigger the standard deviation you have, the more difficult it becomes to obtain a significance value, a p-value which translates into alpha, or alpha which translates into a p-value that is less than 0.05, meaning that you are less than 5% mistaken by rejecting the alternate hypothesis. The more the variability. Yeah, go ahead.
Yeah, in fact, this is kind of part 2 of our talk, but Let me show you exactly as an example. We can go ahead on that an example of the anesthetic. So what you need to know to calculate the sample size you need is to know the standard deviation of your variable. It would be the mean concentration where 50% of subjects don't remember. And we'll say, for example, it's 0.1 Mac, and that's usually what it is. So the width of the interval you're interested in knowing, you also need to know what effect size you're interested in. So if you're interested in effect size that's way, way smaller than your standard deviation, it's going to be difficult. So a standard deviation, then you want to look at your sample size needed is going to be directly proportional to the size of your standard deviation. So the bigger your standard deviation and the smaller this effect size you're looking at, the more subjects you're going to need to study. So it's going to be hard to prove anything. That's essentially what it means. It means that the values are all over the place. So in order to get a clear picture out of all of that, you're going to need to recruit a lot of subjects.
Okay.
So, yeah, and yeah, this just gives you a table of some. When you calculate sample sizes, you go to the what's called the variance here, or the effect size over the standard deviation, and essentially the larger the standard deviation is, the more subjects you're going to need. So W over S of 0.1 has a large standard deviation. So you're going to need to recruit 2,665 subjects per group if you want this level of certainty, versus way down here where your standard deviation is very low, you're going to require only a handful of subjects. So it is the size of the standard deviation is really powerful in terms of being able to prove anything now, or to be be able to have enough subjects in order to be able to determine with any certainty that you do or don't get an effect. So yeah, the size of the standard deviation is really important. And if you and sometimes you can make some measurements and get an idea of the standard deviation, then that's powerful going forward. It can help you decide whether something is worth studying or not, or if it's going to be a big expensive study, or you can do a small study at your own institution that's going to be relatively easy to manage.
Questions? Okay.
I have a questions about meta-analysis.
About?
Sure. Analysis.
When we wanted to do meta-analysis, do we need to take information from the paper before that?
Do we need to, sorry, to do what?
To take a confirmation letter from the people who published the letter?
Oh, do you need the permission of the authors of the other papers?
Oh, no. No, generally not. I don't think so. I think that's, I've never personally written a meta-analysis. So I have colleagues who have, and I would have to ask them, but I don't think you need permission from the authors of the studies. But what you usually do need to get is, people often get is they have to apply to what the Cochrane collaboration, and because there are these, you have to apply and say I want to study the combined, what's known from combined studies on something, and then they will essentially allow you to do this meta-analysis with the Cochrane collaboration. There are other, you can do your own, what they call systematic review, which is not quite a meta-analysis, but you can do a database, search some existing databases, and usually people use PubMed and Embase and a few others, and you search with defined words, keywords, and so forth, and look, and then decide in advance what criteria you'll use for a high quality study, or whether there was blinding, or whether there was whatever it happens to be. You decide in advance, and you can do that certainly on your own without anybody's permission, as long as you can get from their publications the level of data you need to make a conclusion. Now, one of the problems with meta-analysis is that you only see what's published. You can't get inside of their databases and their computers to really look at the data. So you're trusting the publication, and there's publication bias, and people tend to only publish studies where they had an outcome that they could talk about. Hey, look what I found. I found out that I could reject the null hypothesis, and the alien stole my socks, or whatever it happens to be. And so there tends to be some bias in public if all you're doing is looking at published studies, and you're only looking at it to the depth that has been published. So yeah, it's a problem. But if you're interested in meta-analyses, I can put you in touch with somebody who does a lot more of it than I do.
So maybe send her your email and a private message. And
yeah, I mean, I have a couple of colleagues who know a lot about this, and I would be happy to pass your questions along.
Okay, Majdi is one of the people interested in research, so yeah, send Dr. Eshima your in a private message. Don't be putting your email on Facebook. But anyway, all right.
Okay, I have another questions.
Yes.
Yes.
When we do abstraction, I find that there is a slight difference between the abstraction of a case study and abstractions of a study or retrospective study. So how can I formulate this?
An abstract, Magdi? I'm sorry, what are you talking about? An abstract?
Oh, you're talking about publishing an abstract?
Magdi?
Yes, I speak about abstracts.
سؤالك ايه؟
If I wrote abstracts, so I found there is a slight difference between writing abstract for a study, retrospective study, and for case study. How can I manipulate with this?
Oh, you're talking about doing a case study, like, or an abstract. Well,
ماشي اسألني بالعربي وهترجم.
Are you talking about a case
ماشي.
here?
لو محصلة من الواحد يكتب study في اختلاف بين الدراسة اللي بتنعمل عن حالة واحدة وبين الدراسة اللي بتعمل عن مجموعة مرضى أو عن مرض معين. كيف أقدر أسوي؟
اسمع مجدي، في حدا عنده الميكروفون شغال. اظن حمام ده. ايوه حمام ده وهو سكر. اوكي احكي يا مجدي. I think he was having a tough time explaining this and there was also some noise. Go ahead. مجدي. بردعي. You're not talking. سامعك بس انا مش سامعك لانك انت مسكر ميكروفون يا حبيبي.
ماشي.
اوكي.
لاحظت لما كنت بالابستراكت انه في فرق بين الابستراكت بنعمل عن مثلا كومبليكيشن او عن حاله واحده وعن ابستراكت بنعمل كاستدي عن اوتكم او عن ريتروسبكتيف ستدي. فكيف بيقدر الواحد يميز الحالتين هذول خاصه في الكتابه؟
في الكتابه ما بتفرقش. Okay, here is Magdi's question. He notices that abstracts deal with different types of things. There are abstracts who deal with one case report, a medically challenging case, and there are abstracts that deal with extensive prospective or retrospective studies. And
everything.
My answer is, yeah, I don't know what you. My answer is that they get allocated to different sessions. But
yeah, there are different. I can tell you that abstracts are sort of an opportunity to publish a lot of information that that the journals won't publish, and plus a lot of people also will write preliminary findings from what is going to become a manuscript also in abstracts. And I think abstracts are a very or a somewhat less formal way of just everybody getting together and sharing what they're working on. Whether it's that I did a really challenging case, and here's what I did. So a case report. Case reports are really important and very valuable, and that's a whole other topic that we haven't talked about. But there's also a whole sort of methodology to writing a good case report, and we haven't talked about it, and that would be a whole different topic, and I would be really happy to talk about what I think is a good way to write a case report. Now, you can write a case report as an abstract, or write it as or submit it as a manuscript. There are still journals that accept case reports as manuscripts. So I think that writing good case reports is a whole different skill, and it's very very important. You sometimes see in abstracts also something that's almost a manuscript in progress, or a manuscript that's being put together. Somebody decides to make an abstract out of it. So you can see both. You see a lot of descriptive studies as abstracts. So all of those, there are many ways to make an abstract. I think that the people who accept or reject abstracts usually should know that, and usually they understand that that the purpose of having abstracts is to share everybody to share their the benefit of their experience, and it doesn't have to fall into such rigid quite such rigid categories.
Okay, thank you.
Yes, I think that it's very important. Magdi, certainly, his contribution to the literature has been a case report on something that the Western world doesn't hardly see, hydatid cyst. But there is a lot of information, and one of those days we'll either have a World Journal of Anesthesia to publish rigorously reviewed, peer-reviewed studies and reports from third world countries that constitute 85% of the world, or we'll have to do our own journal, for heaven's sake. But seriously, it's ridiculous that you go to the ASA and it pertains to 15% of the world population, or the European Society, or whatever. So I think that these sorts of things, and I certainly believe in my heart of hearts that small series and case reports are gonna have to become have to come back to being a source of major medical information, because Western countries, some time ago I had a case about a very, very rare syndrome, 1 in 100,000, called CADASIL. And I talked to George Mashhour, if you know who he is. He's the neuro guy, University of Michigan. And he said, I thoroughly, all